Okay, folks, new tape, new section, nephrology. Nausea and malaise. That is so nonspecific. A 72-year-old woman comes to the emergency department complaining of nausea and generalized malaise for the past day. Now, that's an enormous differential diagnosis. So we need more info. No associated fevers, chills, chest or abdominal pain, or other constitutional symptoms. Her past medical history is significant for severe osteoarthritis, which is controlled with ibuprofen. Whoa. Anytime you see the word ibuprofen or naproxen or any NSAID on the boards, that should set a signal off to you that this patient may now have an NSAID-related injury. What are the major organs affected by NSAIDs?
Kidney.
Well, hello, kidney. All right, let's make that number 2 because it's not the most common. What else? Yeah, GI. In the form of what? Diarrhea, heartburn, pancreatitis, cholecystitis? No, of course not. Gastritis, duodenitis, etc. Gastric ulcer and duodenal ulcer. And often presenting with what complication of these? This will help you remember. A little drama. Bleeding. Get it? Red? Okay. All right. Why do people still die of ulcers in this country? Because there's lots and lots of old people taking NSAIDs, and lots for arthritis, for instance, and lots of old people getting ulcers, and lots of old people still dying of GI bleeding from NSAIDs. It can be a fatal problem. Next is kidney. Not appreciated as often as GI, but it can happen, and these patients will develop evidence of a rising BUN and creatinine and the associated symptoms, which can be very nonspecific, like this patient, nausea, malaise, not feeling right, and if it progresses all the way, might give you an end-stage kidney, but that's quite rare, that a patient will develop full-blown kidney failure from some NSAIDs. Lastly, what's the other organ, especially in the elderly? The brain. And that they'll have mental status changes, a little confusion, etc. And so you need to recognize that any elderly person who you're told has a change in mental status, the first thing you do is check the medication list. Because there are so many medications that could cause a change in mental status in the elderly, and one of them is NSAIDs. And there are many, many others, as you know. But certainly NSAIDs, change in mental status, before I do a very extensive evaluation for CNS disease, I'll stop the NSAID and see if the patient's mental status improves. Okay, and that's been a question more than once on step 3, is recognizing iatrogenic causes of new patient problems. If there's a new drug and a new and a new symptom, it's a drug-related problem until proven otherwise. Okay? Because stopping a bad drug is always better than starting doing a lot of tests and starting new drugs to treat the problem caused by the first drug. All right? Now, some of you say, well, in this day and age, with more specific inhibition of the cyclooxygenase pathway, COX-2 specific drugs, we don't see these. Well, that's not true. With the newer generation of NSAIDs, we do see all of these, but fortunately, far less frequently. All right? But they can still occur. All right? So you need to recognize that with the newer COX-2 specific drugs, like rofecoxib, celecoxib, that these are the COX-2 specific NSAIDs, that although these happen less frequently, they still do occur. And if a patient has started on one of these and has GI distress or GI bleeding, I would say, yes, it is still due to the NSAID. And that would be my first concern. Does it happen less frequently? Yes, far less frequently, but all of these can still occur because the COX-2 selectivity is not 100%. So you will still get some non-specific, non-selective COX inhibition. All right? And that is what we're using them for, is for the cyclooxygenase inhibition, typically to reduce inflammation and decrease pain. These, and by the time you take the exam, there might be 3 other drugs, just like there are probably 20 NSAIDs by now, the non-specific NSAIDs. You might see many other drugs, and they will end in the word coxib. Okay, these are the 2 that are already clinically available. All right, COX inhibition. Get it? Coxib. Now, let's go back to this case. Our patient started on ibuprofen. Let's say I didn't, on the boards, I don't know how to break this to you. They don't have a heading for each case, nephrology case. So I don't know what this patient has. All I said so far is the patient has ibuprofen on board and is going to maybe very well develop a NSAID-related complication. All right? So she's controlled with ibuprofen. She had a recent flare-up of back pain and has taken, quote, a number of extra pills. All right? So again, more information that they want you to think about NSAIDs. She appears to be in no acute distress. Vital signs are afebrile, blood pressure is okay, maybe on the low side for all I know, tachycardic, and respiratory rate is fast. She's tachypneic. Mild jugular venous distension, a heart that is mildly tachycardic but is otherwise normal, and left basilar crackles in her lungs. Abdomen is soft, non-tender, and no hepatosplenomegaly. There is 1+ bilateral lower extremity edema. Now, there's a lot going on in this patient, all right? And from here, let's think what kind of questions I could ask about this. Well, I probably want the boards to give you a little more information before I would start asking questions. I can't say what is the cause of this patient's problems right now. The differential, I don't have enough information yet. If I told you that the BUN was 30 and the creatinine was 3.8, well, then they might say, and they give you all the other laboratory values are normal. They'll say, what is the cause of this patient's clinical presentation with that BUN and creatinine and these findings? You say, wow, the patient has significant renal insufficiency, and I need to stop the NSAIDs, and I need to think about what other complications may happen from her renal insufficiency. All right? But getting an elevated BUN and creatinine with this clinical constellation of symptoms should make you think that it's the renal insufficiency causing all of this, because the fluid overload might not be because of a failing left or right ventricle, but can just be because of lack of ability to excrete the normal amount of volume every day through the kidneys, and the patient's ending up with jugular venous distension, which is a sign of right-sided volume overload, and some crackles in the left base, which is signs of left ventricular volume overload. All right? So let's talk a little bit about our approach to the patient with renal insufficiency. Now, often the patient will present with something nonspecific, like this patient. And in the question, you'll be told the patient's laboratory values indicate that there is a increase in BUN and creatinine. And then your job is to think about why that is, because figuring out why the patient has a new elevation in BUN and creatinine will help determine how to further evaluate that patient and manage that patient. So let me talk to you now about my scheme of thinking about renal insufficiency, meaning defined in a very practical way for the exam as an elevated BUN and creatinine. First of all, the question will make it clear to you, or should at least suggest to you, whether this is a brand new change or if this is an old problem. For instance, they tell you the patient's had diabetes for 40 years, they're insulin dependent since they're 10 years old, and they've had hypertension for 30 of those years. You know that an elevated BUN and creatinine didn't happen overnight. Okay? But an acute change in the patient's symptoms, nausea, vomiting that wasn't there before, never been volume overloaded before, and now they are, and the BUN and creatinine is elevated, you have to wonder whether that's an acute change. So, what are the causes of renal insufficiency? Well, if you ask the question like that, there's an enormous list of things that cause renal insufficiency, and it's not helpful to memorize lists for a situation like this. I like to think of all renal insufficiency as falling into one of three categories. Number one, that they have intrinsic renal disease, that there's a disease actually in the kidney, and that's why the patient has renal insufficiency, again, defined as elevated BUN and creatinine, versus those patients that I think the etiology will make this colorful for you, pre-renal etiology, meaning the disease is not in the kidney. The problem is not in the kidney. Is a problem pre-renal, before the kidney. Namely, not enough volume getting to the kidney. Not enough volume getting to the kidney, obviously nothing in, nothing out. The patient's going to develop oliguria, elevated BUN and creatinine, and the signs and symptoms of renal insufficiency. And we'll talk about what causes this. Lastly, there are things that cause renal disease that are not related to reduced flow to the kidney, that are not related to disease within the kidney, but are related to things after the kidney. And we call those post-renal causes. Okay? Now, again, don't memorize lists, but this is very easy. Pre-renal, renal, and post-renal. Let's talk first about pre-renal causes. You have a kidney. Here's your kidney. Here's your glomerulus. Here's your renal artery coming into your glomerulus, right? You have your loop of Henle, your proximal convoluted tubules here, your distal convoluted tubules here, and then stuff gets out of the kidney into the ureters, bladder, etc. All right? The problem in patients who are pre-renal, all right? The pre-renal patient is there is some reduction to blood flow getting into the glomerulus. All right? Now, what causes reduced blood flow into the glomerulus? Well, anything that causes intravascular volume depletion will cause less blood flow everywhere. And just like you don't perfuse the brain and you get a little goofy, you don't perfuse the heart and you get ischemia, you don't perfuse the kidney stops working. It's the first manifestation is it'll stop peeing. You're very dry, you don't pee all day. All right? Your BUN creatinine starts to rise, and it starts to rise in a particular pattern. What is the pattern of someone who's pre-renal? Again, we mentioned this earlier in the emergency room tapes, a long, long time ago. You have an elevated BUN creatinine ratio greater than 20:1. Okay? This means the patient is sort of concentrated, not enough volume. What can cause that? Obviously, anything that causes hypovolemic situation, anything where there's volume loss, anything from just plain old dehydration. You went for a long run on a hot day and you didn't drink enough when you finished, you could get a bump in your BUN creatinine. This is something people come to the emergency room, they go out for a jog, they come in. No, but if you go out for a marathon run and you haven't drank sufficiently, there will be patients in the emergency room after every marathon who will present with significant renal insufficiency. Okay? So dehydration of whatever cause. Sometimes you lose that volume from insensible losses, sometimes you lose it through blood loss. So any cause of blood loss, if severe enough, can cause pre-renal azotemia, etc., etc. Besides volume loss, either insensible losses through the skin, or third spacing in a patient with pancreatitis, or a patient who's had massive bleeding, what else can cause this same effect? Let's say I tell you there's a situation where the patient has adequate intravascular volume, but still has a very high BUN creatinine ratio. So enough flow in the pipes, but not enough flow getting into the kidney. And I tell you, not only does there seem to be intravascular volume that's adequate, there seems to be too much. Patient has jugular venous distension, sitting upright. There's jugular venous distension to the angle of the jaw. On lung exam, I hear rails from the bases all the way up both lung fields. Patient is obviously volume overloaded. There's peripheral edema. There's a lot of volume. I should have great kidneys. Look at all this perfusion that should be coming to the kidneys. What's the problem in the patient I just described? They have congestive heart failure, and the problem is not one in volume. They got too much volume on board. The problem is that they have no forward perfusion pressure. We call that forward failure. When I just described in terms of the veins and the lungs, that's backward failure. Things back up from the left ventricle, congestive heart failure, pulmonary congestion, pulmonary edema. Things back up from the right ventricle, jugular venous distension, hepatomegaly, ascites, and peripheral edema. That's the backward symptoms. But think about what's the problem going forward. You're not perfusing organs. Patients CHF might not be thinking so clearly. If they're not perfusing their kidney, they're not going to be peeing well. Their BUN creatinine starts to come up. So the treatment for the patients who are dehydrated have blood loss is obviously giving them more volume. If I have a patient with CHF with an elevated BUN creatinine, giving them more salt is the last thing I want to do. I don't want to give them more intravascular volume. I, in fact, want to get volume out of them. These patients, I'm going to try my best to fix their congestive heart failure and do things that will increase the forward flow. Okay? And in cardiology, you talk about all the things that are afterload reducers. You talk about the things that are positive inotropes to get better flow to the kidneys. And even in CHF, you talk about things to do to specifically give you renal vasodilation. And what drug is that? Low doses of dopamine. Low doses of dopamine are specific for the renal vascular bed to give it a little more renal vasodilation. So you have dry patients, volume loss, volume overload. Let's say I tell you I describe a patient, the question describes a patient who is euvolemic, not too dry, not too wet, still has a high BUN and creatinine. What am I going to think about as a problem in that patient? If the BUN creatinine ratio is high and the patient has renal insufficiency. Let's say I tell you it's a young woman with hypertension in her teenage years. Well, again, I got normal amount of volume, I got a normal heart, no evidence of volume overload, no evidence of heart disease, but I have evidence of decreased flow. I think if it's a problem, maybe it's a problem in renal artery stenosis, meaning there might be enough volume, but that renal artery is stenosed. If it's a young woman, what's the etiology of her renal artery stenosis? Is it atherosclerosis? No. It is fibromuscular hyperplasia. Okay? And that is usually unifocal in one area of the renal artery or the renal artery branches and in one kidney, and is often treatable with angioplasty of that lesion. All right? And that will take care of the patient's renal artery stenosis, improve the flow to the glomerulus, BUN and creatinine come back to normal, and the patient's renal insufficiency resolves. Okay? And it might be all that they need in their hypertension will resolve with adequate flow. Okay? So renal artery stenosis, another important cause of patients being pre-renal. Let's say I give you that same picture, euvolemic, high BUN creatinine ratio, renal insufficiency, and I tell you it's a 50-year-old guy, not a 19-year-old woman. What do you think about then? And I tell you that on your diagnostic imaging, and we have a case later on about renal artery stenosis, on our diagnostic imaging, we have evidence of renal artery stenosis. What's the cause in that patient? The older person with a long history of hypertension is atherosclerotic. It is usually not unifocal and unilateral like in the fibromuscular young woman. It is diffuse, not unifocal but multifocal, involves many branches and both kidneys. And so it's usually not treatable by angioplasty. Okay, usually requires medical management. All right, so that is the pre-renal patient. The patient has an elevated BUN creatinine, the ratio is high, and there will be one more thing that you will do to confirm that the patient is in fact, quote, pre-renal, as the etiology of their renal insufficiency. And what simple test will you do? Will you do renal biopsy? Will you do sonogram? No? No? Do you do urine gram stain? No. Do you do urine analysis for protein? No. What will I do with the urine? Urinary sodium. I'll measure a urinary sodium. So if you have a patient and you suspect a pre-renal etiology, and they've already given you the electrolytes, the one test you'll order is urine. And they might even say urine analysis for protein, urine analysis for red blood cell counts, urine analysis for gram stain, urine analysis for glucose, urine analysis for serum sodium. It's serum sodium. Because what will the serum sodium be in a patient who's pre-renal? Remember, just think about it. You don't have to be renal physiologist. The kidney is seeing low flow. The kidney thinks it's dry. And I'm going to scare you with words like renin, angiotensinogen, angiotensin 1, angiotensin 2, aldosterone. Remember all those scary things from step 1 and step 2? You just need to know that they get turned on and result in aldosterone release, all right, from the adrenal cortex that goes to the distal convoluted tubule, says, hey, not enough flow. That means we're dry. So conserve sodium. Okay? Keep sodium back in here. Get rid of some potassium if you want. Get rid of some hydrogen to make electron neutrality. But hold on to the sodium. I'm a sodium avid, very eager reabsorber. So if I'm absorbing all the sodium, it's not getting out to the ureter. It's not getting out to my pee. The urinary sodium is less than 10 milliequivalents per liter. Now, do you need a liter of urine to know this? Do you need a 24-hour urine collection? No, a spot urine. Have the patient pee in a cup. Hopefully you haven't just given them diuretics, which you wouldn't really do if they're pre-renal, unless they have volume overload from CHF. Once you give them a diuretic, that will affect their salt reabsorption, right? And you're going to influence this test. So before you give a patient diuretic, if they're pre-renal, the test to do to confirm your suspicion is urinary sodium, and it should be less than 10 milliequivalents per liter. A regular spot urine. All right? Now, how do we treat these patients? You treat the underlying problem. They're dehydrated, blood loss, we'll give them fluids, we'll give them blood if necessary, CHF, make the heart work better, maybe try and diurese the patient, get some of the volume circulating out through the kidneys. Renal artery stenosis, we talked about if it's unilateral, unifocal, fibromuscular in a young woman, we're going to probably do angioplasty. In the older man or older woman who gets atherosclerotic renal artery stenosis, usually we're going to manage them medically. All right? The diagnostic test will be suggested by the clinical presentation. You get a urinary sodium, and then you correct the underlying problem. All right? That's your pre-renal causes of renal insufficiency. Let's move on, go across the board, and we'll move on to talk about patients with intrinsic renal disease. Get this out of the way so it doesn't distract you. And now, let's think about, break up the kidney into its various components. And now we're beyond the pre-renal area, and we're into our glomerulus. So you can have glomerular disease. We'll talk about how we'll make that determination. We could have tubular disease, and that the classic form of that is acute tubular necrosis. And we could also have interstitial disease. And there are classic presentations of all of these. Let's start with the one that scared you the most on step 1, where you had to learn 8 different forms of glomerulonephritis. If you have inflammation in the glomerulus, and this is in fact probably of these the least common cause of especially an acute deterioration. All those forms except one, meaning diabetic glomerulonephropathy, most of those diseases of the glomerulus are in fact quite rare. Minimal change disease, focal disease, membranous disease, membranoproliferative disease, they're actually all quite rare. And you're not going to be able, asked to, on step 2, step 3, make a clinical distinction between, say, membranous and membranoproliferative. All right, we'll talk about one specific form of glomerulonephritis in one of the later cases, and there's a very classical presentation. So we'll talk about one very specific form of glomerulonephritis. But for step 3, again, these are not the renal boards. You're not going to be asked to interpret renal biopsies, but you will be expected to know that a patient with renal insufficiency who has intrinsic renal disease, when to suspect a glomerular problem, when to suspect the patient might have glomerulonephritis, inflammation of the itis of the glomerulus, and what signs and symptoms or lab findings will you get in a question to tell your patient has glomerulonephritis. Well, there's going to be blood in the urine, but more specifically, lots of people have blood in the urine. Every menstruating woman will tell you she might see some blood in the urine. You have a kidney stone, you'll see blood in the urine. That's very different than a glomerulonephritis. What's more specific than blood in the urine? Red blood cells in the urine in the form of casts. So when you do a urine analysis now, we're doing a urine analysis under a microscope, a microscopic examination, different than our urinary sodium. Don't just say urine analysis and think you've solved the problem. You got to tell the lab what you're going to do with that urine analysis. You're going to do a microscopic examination of the urine, and if on your slide you see, we'll do this in living color, you see red blood cell casts, what does that mean? And they're not hard to see. And they might give you a stain of a urine that just shows red blood cells clumped up in casts. That is pathognomonic, specific for a glomerulonephritis. Doesn't tell you whether it's membranous or membranoproliferative, etc., etc. It tells you the disease is in the glomerulus. So your first thing you'll do if you suspect a glomerulonephritis is you'll do your microscopic urine analysis. And if you see this, you'll go to what diagnostic test? Renal biopsy, which is not something we do casually. We're now taking a needle and sticking it into your back and hoping that we don't hit some major blood vessel, hoping we don't stick the needle somewhere it shouldn't, and we'll send that biopsy to the pathologist. We try and do as few renal biopsies as possible because, again, of the risk of doing that examination. And then we'll send this and we'll find whether there is or isn't glomerulonephritis. Right? There are not that many indications for renal biopsy. And again, you're not going to be asked to interpret renal biopsies, but you'll need to know when you're going to order a renal biopsy. That's going to be when you see red blood cell casts. What is the other finding that is typical of patients with glomerulonephritis in the urine? A lot of proteinuria. All right, so proteinuria is not specific for glomerulonephritis the way red blood cell casts are, but if I see lots of proteinuria, if I see the patient has nephrotic syndrome, which means lots and lots of protein, over 3 grams a day, 3.5 grams a day of protein in the urine, even though, again, I said proteinuria is not specific for glomerular disease, when it's in that range, when you have lots and lots of proteinuria, that is glomerular disease. And I'll think about whether I can do a biopsy to give me a specific diagnosis. Okay? So that's the glomerular diseases. And we'll talk about them as they come along. In the other cases, the ones you need to know, particularly the diabetic lesion, glomerulosclerosis, and the one called minimal change disease that often presents just with some mild renal insufficiency and lots of nephrotic syndrome. So let's move out of the glomerulus and talk about tubular disease, acute tubular necrosis, which is the most common cause of renal failure that happens acutely. Now, we talked already about pre-renal, right? That you have hypovolemia coming to the kidney, and if nothing in, nothing out, your BUN creatinine starts to rise. What do you think would happen if I kept you hypovolemic for a long time? Or if I kept your perfusion pressure in your kidney low for a long time? In other words, I have congestive heart failure with poor forward flow. What happens to any organ when it's not perfused? It starts to necrose. Just like you have myocardial necrosis with poor perfusion through a coronary artery. If I have too much poor perfusion to the kidney, I'm going to get acute tubular necrosis. All right? Now, with acute tubular necrosis, the most common cause is often pre-renal that's gone on too long and giving you acute tubular necrosis. ATN. So you got to find the cause of your pre-renal azotemia. Azotemia, I'm just meaning elevated BUN and creatinine, and fix it before you do permanent damage to your tubules. How do I know when a patient has no longer just plain old pre-renal azotemia and that they've already gone on to have acute tubular necrosis? Well, remember, what is the hallmark lab finding of a patient with pre-renal azotemia? Elevated BUN creatinine and, more specifically, urine sodium. In a pre-renal patient, urinary sodium is less than 10 milliequivalents per liter. Because, again, the kidney is trying very hard. The tubule, distal convoluted tubule, is trying very hard to reabsorb sodium. But now, if my tubules are dying, I can't reabsorb sodium, so I go from a sodium reabsorptive state, a sodium avid reabsorptive state, I go to a sodium wasting state. And the urinary sodium, which had previously been low in my pre-renal patient, when I find that it is now more than, say, 20 milliequivalents per liter, and even considerably higher, those patients are now developing acute tubular necrosis. All right? And those tubules are gone. And the idea is to correct whatever is reversible so you don't have further acute tubular necrosis. All right? So one cause, a very common cause of acute tubular necrosis, is pre-renal azotemia left untreated for too long. And you'll know that's the case because the urinary sodium, which had been low, is now rising. Okay? So we covered acute tubular necrosis from dehydration, hypovolemia, pre-renal azotemia. What other causes, classic causes of ATN, acute tubular necrosis, will you see? ATN. It's pre-renal that went on too long. What else? Drugs. Okay. When in doubt, when you're on rounds, after you pass step 3, or you might already be doing your residency or have done your residency, people said, what else can cause this? Just say drugs. Always an answer. Drugs. then you got to be aware that the attending might say, well, what drugs, doctor? And then you have to know the answer to that question. But always think about drugs as causing any problem. What drugs cause ATN? An acute tubular necrosis, most commonly the aminoglycosides. Unfortunately, we see this less and less because we don't use aminoglycosides so much anymore. Why not? Because aminoglycosides so frequently cause ATN that over the last 20 years we found that most things that we treat with aminoglycosides, we've developed newer gram-negative antibiotics to allow us to avoid aminoglycosides. So this is the most common, but there are still times when this is the drug of choice, particularly patients with enterococcal infection. But other than that, we're going to try and avoid gentamicin and the other aminoglycosides, tobramycin, kanamycin, etc., whenever we can. What else besides drugs in the aminoglycoside family? What else do we put in patients that can cause acute tubular necrosis? Dye, radiocontrast dye. And since it's a dye, we'll make it colorful. See, color, get it? Contrast? Radiocontrast dye. All right? Which patients in particular are prone to radiocontrast-induced acute tubular necrosis? Patients who are diabetic to start with, probably have some underlying renal disease. Patients who are dry. So when you send a patient, especially a diabetic, to the radiology department for a radiocontrast study, make sure they're well hydrated. There's one other disease that in particular is prone to radiocontrast-induced ATN. And it's because, I'll give you a hint, it's usually an older person, some anemia, their tubules are already getting plugged up with protein, a particular kind of a protein, one protein, one monoclonal protein, right, multiple myeloma. Since the tubules are already getting plugged up with a monoclonal kind of protein, some immunoglobulin in a monoclonal malignant sort of way, any further injury is not going to be tolerated while a patient develops acute tubular necrosis. So any multiple myeloma patient is sent for a radiocontrast study. I can't promise you anything, but there's a good chance that patient is about to develop renal insufficiency. All right? So you need to prevent that by trying to think whether you really need to give radiocontrast, and if you do really need to do it, then making sure your patient is very well hydrated. Okay? So those are the causes of acute tubular necrosis. What we try and do is correct the underlying problem. We stop any offending agents. Once you've already given the radiocontrast, if it's there and the patient is developing ATN, you want to keep that radiocontrast getting flushed through the kidney, so we'll try and hydrate the patient. Okay? And in fact, in all of these, what we're interested in a patient with ATN is taking a patient who has ATN and making sure that they continue to pee. All right? Some patients with acute tubular necrosis pee plenty, and we call them non-oliguric ATN. Their problem is not in things getting into the kidney. They got plenty of stuff coming to the kidney. Their problem is that their tubules aren't working. They don't conserve sodium, and they're going to have enough urine output, and they might be non-oliguric ATN. Those patients, in fact, have a better prognosis than those patients whose ATN is so bad that they're not making urine. We call that oliguric ATN. What number of cc's per hour do we consider something oliguric versus non-oliguric? About 30 cc's an hour. So if your patient gets aminoglycosides and or radiocontrast, and their daily urine output is, let's say, 300 cc's a day, 10 or 15 cc's an hour, what you need to do for that patient, or you've stopped the aminoglycoside, the radiocontrast has already been given, what you need to do is hydrate that patient, and if necessary, even give diuretics to keep the water flowing through the kidneys, get the kidneys flushed out, flush out those necrotic tubules, and if you convert a oliguric, low urine output patient with ATN into a higher volume urine output, that patient will do better. Okay? So you want to maintain good urine flow in your patient with ATN. That's about all you could do once you've already treated the underlying problem. Okay? So that's acute tubular necrosis. You could have intrinsic, so we talked about glomerulonephritis, red blood cell cast, proteinuria, ATN, low flow to the kidney, or something intrinsically damaging to the kidney, like aminoglycosides or radiocontrast. And lastly, let's talk about problems where there's itis in the interstitium. There's interstitial nephritis in the kidney. What produces that? Typically drugs. All right? So let's move on to interstitial nephritis. And again, just to reiterate, within the kidney, if I'm thinking of glomerulonephritis, urine analysis, look under the microscope, red blood cell casts, proteinuria on dipstick. If I have evidence of glomerulonephritis, stick a needle in, kidney biopsy if I think it's something that will be treatable. Acute tubular necrosis, I'll suspect it based on the clinical history. Patient's too dry, patient's got aminoglycosides, patient's got radiocontrast dye, particularly in a diabetic, particularly in a patient with multiple myeloma, where how will I make the diagnosis? The clinical history and the urine analysis now shows me urinary sodium, again, greater than 20. Okay? What do I do here? Try and maintain adequate hydration and urine output. And lastly, let's move to interstitial nephritis. When will you suspect it? You'll be suspecting it when you are given a cause to develop interstitial nephritis, meaning you're given a drug that causes this allergic interstitial process. Meaning, it's usually allergic, all right, sometimes known, also called acute interstitial nephritis. What are the drugs that do this? Many of our antibiotics, penicillins, sulfa, cephalosporins. All right? Patient is given these and is now developing renal insufficiency, and we're thinking about whether any of these cause an acute or allergic interstitial nephritis. All right, so I suspect it. How do I go about proving it? Do I put a needle into the kidney to prove it, to show itis in the interstitium? No. All right? We almost never, ever want to do a biopsy in general in the kidney. You certainly don't want to do it for allergic interstitial nephritis. So how will I confirm my suspicion? Again, this is allergic. So what cells do I see when the things are allergic? Eosinophils. So in this patient, we're talking about doing all kinds of simple urine analysis to make a diagnosis of intrinsic renal disease or even pre-renal disease. In the case of acute interstitial nephritis, what are we looking for? Okay, here we're looking for in a urine, we're looking for the pretty pink eosinophils. Okay? Eosinophiluria. All right? Eosinophils in the urine, I bet you the patient's on one of these drugs. And the patient may have not only eosinophils in the urine, but even have systemic eosinophilia. So on a differential, you're giving the patient with renal insufficiency and their urine eosinophils, you're not given. That would make it too obvious. But you're given the fact that they have 15% eosinophils, that's an allergic phenomenon. Look at the drug list, stop the offending drug, and the patient will almost always get better. Don't do renal biopsies. You don't need to do sonograms. You got the eosinophilia or the eosinophiliuria. You have enough information. Stop the drug. The patient will get better. Okay? So those are the major intrinsic renal diseases. Lastly, and the simple, safe, non-invasive tests that you'll do to confirm your clinical suspicion. Lastly, are the post-renal causes of kidney problems. Again, just like pre-renal, the kidney itself might be perfectly normal, but the problem is post-renal, beyond the kidneys, after the flow of blood into the kidneys. Here are your kidneys, here are your ureters, here's your bladder, here's your urethra, here is your urine specimen cup. Okay? Life in the GU tract. Now, I told you there's no I tell you a patient has pre-renal insufficiency. Has renal insufficiency. The question tells you elevated BUN and creatinine. What tells you the patient has noticed a significant decline in how much they're urinating every day. And you look at the urinary sodium, you look at the clinical picture, it's not less than 10, it's not more than 20 to 40. It's 15, it's 20. ATN's usually, I said, more than 20, even greater, it's usually more than 40. Okay? So no cause for pre-renal in the clinical condition. There's no cause for an intrinsic renal disease in the patient's clinical description in the question. But the patient clearly tells you, I'm not peeing as much, and the question tells you the BUN and creatinine is up. So if it ain't pre-renal, and there's no evidence of intrinsic renal disease, you have to wonder, is there some outflow obstruction from the kidneys, blocking the kidneys' outflow, causing decreased urine output, and BUN and creatinine is backing up and rising in the bloodstream. All right? Now, where do you ought to put an obstruction to cause post-renal insufficiency? If I put an obstruction here, let's say a stone right in the area where the ureter is exiting the kidney. Will that give me renal insufficiency? No, because this other kidney will compensate just fine. Flow will increase through this kidney. Let's say I put a stone here, or a tumor here. Will that cause renal insufficiency? No. Stone in the ureter? No. Stone in the ureter entering the bladder? All right. The ureterovesicular junction? Will that cause renal insufficiency? No. Kidney stone might cause a lot of pain, but not renal insufficiency if it's unilateral. All right. How about if I got not one stone, but I have the bad misfortune to have a stone on each side? Well, that's actually pretty rare. Why should you form a stone on either side at the same time? It happens. People who form stones usually have some underlying metabolic process that causes them to form stones, and you got the bad luck that you have them bilaterally. Yes, you can get renal insufficiency. But it's a lot easier to put an obstruction in a single place rather than look for two separate explanations for obstruction. Where will the obstructions be that will typically cause urinary tract post-renal nephropathy? Where will they be? In a man, what sits behind the prostate? That red-hot organ. What sits behind the bladder? The prostate. All right? And what's the most common cause of a large prostate in a man? BPH, benign prostatic hypertrophy. With age, the prostate swells in a symmetric fashion. It might be firm, but it's not rock hard, and it presses on from behind, it presses on the urethra. And the male say, I can't pee as much as I used to. Or when I got an urgency to go, but I go and just a little bit comes out. Or I got to wake up 2-3 times in the middle of the night, and each time I get up, there's just a few drops, and then I go back to bed. Or when I go to the bathroom and there's a long line behind me, that line gets a lot longer because I stand there and I strain, I push, and I squeeze, and nothing's coming out. All right? My urinary stream is more hesitant. Okay? That's BPH. Certainly, cancer can do the same thing. If it compresses the urethra, now you have a single lesion that will cause bilateral obstruction. Okay? Or a woman who has a large pelvic mass that causes obstruction in a strategically located place whereby the bladder can't empty. All right? So in men, BPH, and women, I'd worry about a pelvic malignancy. How do I make the diagnosis of a post-renal obstruction? Pre-renal, we talked about urine analysis. Renal, intrinsic renal disease, we talked about all the various steps. What have we not talked about that is the step, the next thing to do in a patient in whom you suspect post-renal nephropathy? You'll get a sonogram. It's not invasive. Every place has it. I mean, not every doctor's office, but every radiologist has it. In the emergency room, they have access to it. Every hospital obviously has many sonogram machines. And what will it show you? It will show you, if it truly is post-renal nephropathy, it will show you bilateral hydronephrosis. Both kidneys are enlarging because of obstruction. Or at least bilateral hydroureter. Both ureters are enlarged. You can't make the diagnosis of a post-renal obstruction as the explanation for renal insufficiency if your sonogram is normal. All right? Get the sonogram. If you show bilateral dilatation, that clinches your diagnosis. If on the other hand you get it and you just happen to see one dilated ureter and the other one's fine, you've identified one dilated ureter, but you haven't explained why this patient has renal insufficiency. So don't be fooled. They give you a sonogram and only one side is obstructed. You've got to keep looking for their cause of renal insufficiency. Okay? So that is the approach to the patient with renal insufficiency. Think about what they're telling you in the clinical question, and then in your mind, ask yourself, are they describing someone who's pre-renal, someone who has a renal intrinsic problem, or someone who has post-renal kidney obstructive uropathy? There I will get a sonogram. Okay, let's go way back to the beginning of this patient when we talked about what might be causing her renal insufficiency. Remember, what was it? If you can remember back weeks ago to when we started this case, it was ibuprofen. Now, out of all those mechanisms, where will ibuprofen work? Do you think it's pre-renal, intrinsic renal disease, or post-renal? Obviously, intrinsic renal disease. Now, let's look at some of the results of the test results we're given this particular patient. In our initial diagnostic plan, we get a CBC, and what's that? Well, what do you expect the CBC to be? Do you expect the patient to have an anemia from their renal insufficiency? Do patients with chronic renal failure have anemia? Yes, that's chronic renal failure. And why do patients with chronic renal failure have anemia? Because the kidney is chronically failed. And what is one of the things the kidney makes? Erythropoietin. Right? And if your kidney doesn't work, one of the things it doesn't make is erythropoietin. So you get a chronic anemia of end-stage renal disease. When it happens acutely, you don't get that anemia because it takes a while for the loss of erythropoietin to become evident. So the CBC being normal doesn't surprise me. Sodium of 138, that's not helpful one way or the other. Potassium is high. Is that common, uncommon in patients with renal insufficiency? Fairly common. And the height of the potassium, how high it gets, and how long it takes to get there will determine what you need to do about it. This patient, I'll probably just try and diurese her after I make sure she has no acute changes on her EKG. All right? But hyperkalemia can be an indication, if it's severe enough, to be an indication for dialysis. Chloride is not helpful. BUN is very high. Creatinine 6.3. So this patient, do they have a high BUN and creatinine? Yes, very dramatically so. Is it an elevated BUN to creatinine ratio? No. All right, this is intrinsic renal disease. There's trace proteinuria on a urine analysis. No red blood cells, just some protein. Does that exclude the possibility of an NSAID-induced intrinsic renal disease? No. Mild proteinuria doesn't tell me much of anything. It certainly doesn't suggest a glomerulonephritis, which I had no reason to suspect. pH, she's acidemic, 729/20/80. Let's forget about the AA gradients for now. We're not talking about pulmonary or ventilatory status now. But what's her acid-base problem here? pH is acidemic or alkalemic? Acidemic. And then I look to see is it metabolic or respiratory. PCO2 is low. PCO2 is low, that should mean the pH would be high, but it's not. So obviously this is a metabolic acidosis. And in fact, this patient has not only metabolic acidosis, but is overcompensating. This patient is blowing down her CO2 lower than it should be, lower than it needs to be. This patient also happens to have a respiratory alkalosis. And how do I know that? Well, there's a very simple trick. And that wasn't the point of this particular pH, because we're not going to discuss the differential diagnosis of this particular pattern. But if you want to know what an appropriate compensation for metabolic acidosis is, this number should be this number, within a point or two, all right? And that works all the way down to a pH of about 7.1. The fact that this is lower than 29 and substantially lower than 29 tells me that this patient has a respiratory alkalosis in addition to a metabolic acidosis, okay? And we're not going to talk about the differential. In fact, in NSAID-induced renal insufficiency, that's not really what you usually see. You'll usually just see a mild metabolic acidosis. She has a small left pleural effusion. Why is that? Well, she's an old lady. Maybe she does have a mild element of congestive heart failure, so it's backing up and she's getting pleural effusion. And her calcium and uric acid levels are normal. Why would I check calcium and uric acid levels? Well, I wasn't really thinking she had kidney stones, but if she had kidney stones, it might be related to hypercalcemia. It might be related to hyperuricemia. And in fact, if this was a CCS case, this would be very low on my list of things to check in this particular patient, because you're wasting money on a calcium and uric acid here. Right now, it's an acute renal insufficiency. It has no relation to stones. You don't hear that by history. You don't hear that by symptoms, etc. Okay? Now, what else might we do in this patient? Well, this is an old lady, and we're not told about hypertension, but a good way to determine how long a patient's had renal insufficiency, and this is pretty severe, okay? This is pretty severe, this renal insufficiency. Could it be that she has had long-standing mild renal insufficiency and now got tipped over by this added NSAID? And the answer is a sonogram in that case will be helpful, not because we're looking for obstruction. Nothing here suggests obstruction. But the size of the kidneys on an ultrasound gives us a good idea of the chronicity of the renal failure. If her kidneys, let's say this is a normal-sized kidney, and her kidneys look like this, I'll tell you, listen, that's very good. These are normal. These are yours. Why is that good? Because that tells me you have not had, this BUN and creatinine is probably all an acute change because your kidneys are still normal sized. Whereas if the normal kidneys are this, and this lady's kidneys are like this, that didn't get like that from 1 week worth of NSAIDs. This patient has long-standing problems in her kidneys, probably hypertension. Without diabetes, I always think about hypertension. And the kidneys are small and shrunken. So they had substantial renal disease before she got the ibuprofen, and that tells me all of this BUN and creatinine is not going to go back down to normal. She might have a BUN and creatinine that comes down to 2, creatinine that comes down to 2, 3, 4, who knows. But if they look like this size kidney does not get better overnight. Okay? And even when we're evaluating a patient with a glomerulonephritis, let's say, if we do a sonogram, we see small shrunken kidneys, it doesn't matter what the cause of their renal insufficiency is, whether it's a glomerulonephritis that maybe early on would have been responsive to a steroid, or whatever the cause is, if the kidneys are small and shrunken, that's an end-stage kidney. And then I have to think about what am I going to do in terms of renal support. Okay? What do I mean in terms of renal support? Well, I got to do the job of the kidneys that aren't working. So let's talk about acute renal support. Well, acute meaning to take care of the patient now. We're not worried about what we're going to do with her long term. Well, what are the issues we need to address with a patient with acute renal insufficiency? What are our concerns? What are the kidneys supposed to be doing? Well, it's supposed to be getting rid of urine, of volume. So I need to make sure the patient's not volume overloaded. She already has a small left-sided pleural effusion. So how do I treat this? Diuretics. All right? What else am I worried about in a patient with significant, severe acute renal insufficiency like this patient? What other electrolytes? Well, potassium. All right? And the first thing I'm going to do, if I have a patient with K of 5.8, especially if it's acute, what am I going to do? CT, chest CT, head CT, urine electrolytes, urinary sodium, microscope. What am I going to do here? Obviously, EKG. And I'm going to look for signs of acute hyperkalemia. Okay? And if there are signs of acute hyperkalemia, and we're not going to talk about them now, hopefully by now you're familiar with them. If they are, then I'm going to treat with a number of steps, the first being calcium gluconate to reverse the cardiac effects. That doesn't do anything for the underlying hyperkalemia, but it'll protect the myocardium from arrhythmias. Calcium gluconate. Then the other things I could do is give sugar with insulin. Sugar does nothing really. It's the insulin that drives potassium into cells, but obviously I'm giving insulin. I better support her with some sugar. What else can I do? I can give her serum bicarbonate because often renal insufficiency, they're acidemic to start with because they're not getting rid of enough acid. That's going to be our next complication of renal insufficiency. And if I give bicarbonate, it'll drive potassium into cells, out of the intravascular volume into the intracellular space. Okay? So I might give bicarbonate. And lastly, none of these have yet done anything to get potassium out of the body. I want to get potassium out of the body. I'll use an exchange regimen orally, K-exolate, with a cathartic like sorbitol. All right? And this will exchange sodium for potassium in the gut. This works in the gut to actually get potassium out of the cells lining the gut lumen, bring it into the lumen. The sorbitol will then flush it out. With that diarrhea, you'll get rid of a lot of potassium. All right? So that's what we're going to check with an EKG. What else do I need to be concerned about in a patient with acute renal insufficiency? What else? Well, I'm not getting rid of my acid. I might be developing an acidemia. We said this patient was 729. Is that worrisome? No. When do I start worrying about it? Oh, when it's 7.15, 7.10, under 7.10, I'm really starting to worry about that this fat patient is getting too acidemic. The body doesn't like to work when it's acidemic. Furthermore, acidemia increases hyperkalemia. All right? So this patient might need bicarbonate. What are the other things that might go wrong? Well, the patient, if they develop enough renal insufficiency, may develop pericarditis. and there's no medical treatment to make this pericarditis worse. You say, oh, pericarditis, just give her some NSAIDs. NSAIDs is where she got here in the first place, okay? So forget that. This patient might need, if it becomes symptomatic, this patient might need dialysis, okay? And uremic encephalopathy, change in mental status. And if it gets severe, can even, when it's acute, can result in seizures, okay? Now, so we have medical tricks to deal with most of these problems. We could diurese the patient. We could treat the hyperkalemia. Don't forget also diuretics for, like furosemide is effective at getting rid of potassium. Hydrogen, we could give the patient bicarbonate if the acidemia is severe. Pericarditis, if it's symptomatic, you got to need dialysis. Encephalopathy, we might also need to dialyze the patient to get them to wake up and perk up a little bit. Not all of these, though, these first three are always going to be treatable medically. If the kidneys are really shutting down, you give as much diuretics as you want, nothing's getting out. So you might need to dialyze for volume overload. For potassium, if all this doesn't work, you should always be able to get some potassium out through the GI tract, but that can take hours and hours. And if the patient has dangerous hyperkalemia in terms of cardiac instability, in terms of arrhythmias, you might need to dialyze the patient to get rid of that potassium more quickly. Remember, the likelihood of cardiac arrhythmias from hyperkalemia is not dependent just upon the level of your potassium, but how long it took you to get that. Patient with slowly progressive renal insufficiency will tolerate potassium to 6, 6.2, 6.4 even, between dialysis sessions. I, on the other hand, if I got some reason to have a K of 6.0, I'll probably have ventricular fibrillation and die, and that'll be the end of this tape. So again, it's not just how high it is, but how long it took you to develop the hyperkalemia. A patient who develops acute renal insufficiency will tolerate hyperkalemia a lot worse than patients who have slowly developed renal insufficiency. If I get persistently acidemic, I have to give a lot of bicarbonate. What's the problem in giving bicarbonate to patients with renal failure? Well, you can't go to the shelf and just get bicarbonate in a bottle and pour it into the patient intravenously. Bicarbonate doesn't come as bicarbonate, it comes as sodium bicarbonate. Right? You have to have a neutral substance. What's the problem with giving a lot of bicarbonate? Well, I'm giving a lot of sodium. Well, that's okay, but if the patient's kidney is so bad that they can't get rid of acid, they probably can't get rid of volume either. So you're limited in how much bicarbonate you could give because you're delivering it with sodium in a patient who has damaged kidneys. Okay? Pericarditis does not have any medical treatment. If the patient is very symptomatic, they're going to need to be dialyzed. Similarly, encephalopathy, particularly if they've gone to the point of seizures, will need dialysis. Whatever uremic toxins are around will keep them encephalopathic until you've dialyzed the patient. So in summary, this patient had an acute exacerbation, well, you don't know if it's exacerbation, or an acute change in her renal status induced by NSAIDs. We're obviously going to stop the NSAIDs. We're going to look at the simple things like a urinary sodium to make sure she's not also dry. All right? In her case, I expect the urinary sodium to be high. There's intrinsic renal disease. There's nothing in her story to suggest obstruction. A sonogram in our patient in this question will be useful, but not to rule out obstruction. I have no reason to suspect obstruction, but to show me the size of her kidneys, to tell me what the duration of her kidney insufficiency has been. And we talked about the issues we need to address in any patient with renal insufficiency, acute or chronic, that will necessitate when they need to start dialysis. And on that note, we'll finish this very long, comprehensive first case.